about how you get the images, how you use the probe, some tricks of the trade, some of the images you should be looking for. Again, today's mostly about normals, and that's where you're going to start. Just like we started with, a normal heart, and we've learned how to identify a normal aorta, and we're learning how to identify abnormal structures in the heart. You'll learn as you use, and so today is certainly about normal. Okay, I have no disclosure. So today we're going to review some of the relevant anatomy of the heart and major vessels. We're going to go just quickly, again, my favorite thing is to talk about the utility of the physical exam. We'll talk a little bit about that. And then we'll talk about the EKG and its role. And then we're going to go on to discoverable cardiac and vascular abnormalities and probe selection and positioning and image interpretation. So, auscultation. Hilarious. What we do is we listen to the heart, and we all know, right? First two heart sounds, right? First heart sound is the mitral valve closing and the tricuspid valve closing, right? So that's the first heart sound. You're apparently supposed to be able to hear a split. I haven't heard that. The second heart sound is the aortic and pulmonary valve closing, right? And we all hear these two sounds. After that, there's a third heart sound, which I think I heard in heart failure patients, where you're filling a large amount of blood into a compliant ventricle. You can hear that third heart sound. I've heard that, I think. There's a fourth heart sound, which is the atrial gallop, which I have not heard. And this is, of course, 10 plus years in the emergency department listening to ill patients. And that's a spilling of blood into a non-compliant ventricle. There are extra heart sounds. There is the murmur, which we will pay attention to. And then there are, I'm just getting my list here. So clicks, plops, snaps, and knocks. Those are real things you're supposed to learn. I don't know what they are. And I've never heard them. Okay, so moving along. It is, we are going to continue to listen to the heart, but, I'd rather look at it. The EKG, this will forever be an important part of what we do when we examine the heart, right? There's no better way to follow the conduction of the heart than to watch a P wave, an atrial depolarization, a period of time while it gets through the AV node, a QRS as the ventricle depolarizes, and then the P wave as it repolarizes. For atrial fibrillation, ventricular tachycardia, it's the cornerstone of resuscitation. It's never going away. But is it a great way to look at the structure of the heart? Put a bunch of electrical leads and measure electrical current, and then tell you something about how the heart is structured? I mean, a little, but it certainly creates a ton of false positives, and it seems kind of silly when we have ultrasound. So, a little reminder about the anatomy. Again, ultrasound is going to let you look right at the heart, and I want everyone to start by learning the walls of the heart. That's the easiest place to start. Start by getting a good view. We're going to talk about in a second the long axis view, peristernal, and then you learn how to measure wall thicknesses. That's going to be step one. Eventually, then you're going to, maybe today, you'll learn how to scan up and get the ascending aorta and get some measurements of that. Okay? The next step in your education, and I think you'll do this today, is to look at the valves. We'll teach you how to do that. Eventually, the coronary arteries, that's going to require increasingly good technology and resolution. So here is a cross-section. There are three cross-sectional levels that you should think about. There's the aortic, the mitral, and the apical or papillary level, right? So you can imagine that. This is the mitral level. And this is where you'll see that fish mouth view that I'm going to show you in a second. I mean, this is an easy view to get in cross-section. The aortic level is a little tougher. You have to understand how the heart sits in the chest to do this study. And you really have to understand how your structure sits in the body to do any study. Basically what you're doing when you do an ultrasound is you're taking like a ninja sword and you're slicing whatever you have into two pieces and then looking at it, right? And if you don't know, if you know your anatomy, it's like setting it carefully on a table and chopping it. If you don't know your anatomy, it's like throwing it up in the air and trying to slice it in the air. You need to understand the base of the heart, where the base of the heart sits. It's like a football that heads towards the left lateral body. So, probe selection. You're going to use basically it's just going to be your cardiac probe. It's got a small footprint. It's phased array, and it's a low frequency, so it can get deep. Best. You're going to learn to do the long axis parasternal view. Now, long axis parasternal view, your probe marker will be towards the right shoulder, and you'll be heading towards the left elbow. So the left elbow to right shoulder is your plane. Okay, about the third intercostal space. Once you think you have that really good, you've got a good image, you're going to turn clockwise 90 degrees. By turning you don't lift your probe. By turning clockwise 90 degrees, you're going to get a good cross section or short axis parasternal view. And I want you to think as you're doing this. And for me, it's hard to remember where I'm supposed to put my marker. And the way you do your marker when you're doing cardiovascular is you're going clockwise from 10 o'clock, 3 o'clock, 2 o'clock or 3 o'clock, and then 3 o'clock again. In a second, I'll tell you where that is. And then 3 o'clock again for subxiphoid, and then turn it all the way around back to the right for your aorta. And I'll show you more about that. But these are the positions, right? So A is the parasternal, C is the apical view. B is the, that's backwards. Sorry. So C on the picture is the apical view, and B on the picture is the subxiphoid view. Sorry about that. Okay, so here's your ninja cuts. So long axis, short axis, aortic, mitral, apical level. This is a beautiful, normal, long axis parasternal view, right? So here's the aorta and the leaflets. Easy to see, right? Aortic root. That's the outflow tract. This is the left ventricle. This is the septal wall, the posterior wall. This is the right ventricle, really just to be thought of as the right ventricular outflow tract. Okay? Mitral valve here. The view that you want to get, you want to freeze when you're doing cardiac, is the end diastolic. That's sort of the traditional time. And when do you know it's the end diastolic? You know it's end diastolic or end of filling when the mitral valve snaps shut. That snaps shut, the aortic valve opens, that's your end diastolic. Okay, this is a bad slide. And the reason it's a bad slide is I, again, only have that picture of the mitral level cross section, and then I show you an apical view. So I'll correct that in the future. But this is the left ventricle. This is the very best way to see the entire circumferential view of the muscles of the left ventricle. And these guys in here are papillary muscles, plus minus the chordae tension. And of course, the right ventricle. The apical view. Apical view you can try today. I don't find it that valuable for what I call frontline purposes, but it is a great way of seeing four chambers, right? In an apical view, you're coming up through the left ventricle, so the majority of what you initially see is the left ventricle, right? Left ventricle, left atrium, right ventricle, right atrium. Subxiphoid view. This is the view that most of us use, especially when we're looking for pericardial effusion or pericardial blood. And this, to do this view, you're going to come down, you actually push up kind of through the liver, but you push in and tilt down and push up. Okay, it's the same way that you do. Okay, so that's that view. That's what this looks like. So again, this is the liver. Now in this view, you're kind of coming more through the right side, so you see the right ventricle first and the left ventricle over here. Okay, the descending aorta and the inferior vena cava. Just a quick reminder, the left side of your body is the aorta, the right side is your IVC. This is about the easiest ultrasound image to obtain. This is the probe position with the marker to the patient's right. And this is what you're going to look for, right? The vertebral body here, the aorta here, and the IVC here. So the aorta is on the left, IVC is on the right, the vertebral body. And I'd like you to try today, if it's possible, to look at the vein artery nerve in the femoral, in the inguinal crease. So the femoral artery, the femoral vein, and the femoral nerve. And this is the position for that. So I'd like to go over a couple normal abnormals. So, and I'd like to see if the crowd can tell me which is which. So this is the long axis peristernal view. Which side has wall thickening, that's abnormal, and which side has normal wall thickness? Left, right? So left is crazy. Where does the blood go? Not a lot of room for it because the septal wall is probably 2 centimeters, as is the posterior wall. So yes, this is very abnormal. This is normal. The short axis view is a little bit tougher, but which of these patients has hypertrophic cardiomyopathy? Everybody has said right, and that's right. So normal, abnormal. You can see that there's serious impingement into the end diastolic volume of this patient caused by a wall thickness, circumferential wall thickness. By the way, hypertrophic cardiomyopathy does not have to be circumferential. It can be spotty. Here's a subxiphoid view. One of these patients has blood around their heart and one doesn't. Anyway, this is a little tougher. Where you're looking here is for where the liver meets the heart, and there should be nothing between there. Any thoughts? Which is normal, abnormal? Left, 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 right, left. So this shouldn't be here, right? It should go liver, heart. Okay? Okay, ascending aorta. Which of these patients has an abnormal ascending aorta? Left or right? Left, left. Throw me a bone, people. Left, right? It's the left. All right? Descending aorta. This happened, right? This would happen in the emergency department where a guy would come in, have a syncopal event, severe abdominal pain, hemodynamically stable in a few cases I saw, but we have to tell surgery to get down here and do something about it. They don't want to come, right? Because we're always wrong in the emergency department. So, before we'd have to take them over to CT and let them die in the CT scanner. But with ultrasound, we could just say, look, dude, this is his aorta. What else do you need? This is normal. This is abnormal. This is not a vertebral body. This is an aorta. So I think I have these a little backwards, but the basic concept is there. When you have an artery versus a vein, and I think Dr. Jackson touched on this, you should be able to collapse the vein, right? It should be easily collapsible. If you can't collapse it, there's something in there, right? So in a duplex study, you do both a Doppler and compressibility of the vein. So one of these sides, both of these sides have a compression, non-compression, compression, non-compression. So which one of these has a normal femoral vein and which one doesn't? It's a little bit harder. Yeah. So left is compressible. Now this image is flipped, but this is the vein and it's not compressible, and there is a clot in there. Okay? So that's it. So any questions, let me know when we're doing the actual study.